All right, everyone, why don't we get started out of respect for everyone's time? We have several hundred people joining us this afternoon. Good afternoon and welcome. My name is Robin Lipson, and I am the Secretary of Aging and Independence for the Commonwealth of Massachusetts. It's a pleasure to be with all of you today for the release of the Massachusetts Long-Term Care Feasibility Study. And I want to start by thanking each of our amazing, knowledgeable speakers, and you'll see them listed here on the agenda, and for each of you joining us for this critical conversation. Before we begin, a quick note for those of you joining us live. Feel free, if you have questions, to put them into the Q&A box, which you'll find on your Zoom toolbar. We'll try to get to some of those questions during our panel session. We're joined this afternoon by two ASL interpreters who will also be on the screens alternating with our speakers. We're very thankful to have them. We also have live transcription enabled for this webinar. You can access the live captions by clicking on the CC or the live transcript button on your toolbar. This webinar is also being recorded and will be available to the public for future viewing. So now let me get on to the content. Long-term services and supports are absolutely critical to Massachusetts residents whose functional limitations or chronic illnesses get in the way of routine daily activities like dressing, preparing meals, and taking medications. We may not want to think about this, but 3 out of 4 of us will need these services at some point in our lives, and very few of us have the ability to pay for this kind of care out of pocket. A small portion of us may have long-term care insurance policies. Others may rely on savings, often inadequate, or may rely on family caregivers, often impacting the health and economic security of their loved ones, or they may spend down to become eligible for assistance under Mass Health. Long-term care is an increasing prevalent issue and pressing problem. But our systems for long-term care are not yet structured to ensure that everyone can access and afford the care they need. It's a priority for Massachusetts as an age-friendly state to think about how all residents can age with dignity and with independence. As one of the first states in the country to be designated by AARP as age-friendly, the designation is more than symbolic. It reflects our deep commitment to building communities, policies, and systems that support people of all ages. Today's conversation is an essential part of fulfilling our age-friendly commitment and marks an important milestone in our shared journey toward creating a more equitable, sustainable, and supportive system for long-term services and supports for older adults with disabilities in Massachusetts. On our webinar today, we'll review the actuarial study that was just completed by our partners at Milliman, which analyzes potential approaches to public financing of long-term care. This work, an important first step, gives us an impartial fact base as a jumping off point for future conversations. We'll hear insights from experts who have worked on innovative public models, such as Washington State's WA Cares Fund, and those who understand the vital role private insurance and private sector partners can play in implementing public solutions. We'll explore how countries with social insurance models have improved both individual and economic outcomes. We'll talk about what it takes to build public understanding and support for long-term care coverage, because let's face it, most people don't realize that Medicare will not cover extended care either at home or in nursing facilities until they are faced with an urgent need. And as we'll discuss today, this issue goes beyond healthcare. It's also about workforce, family stability, economic resilience, and community well-being. It's about making sure people can stay in their homes and communities with the supports they need. It's about peace of mind. We're proud that Massachusetts is taking this first step seriously, studying our options, learning from other states and other countries, and launching a thoughtful public dialogue. And we are committed to moving forward with integrity, transparency, and collaboration. So again, thank you all for joining us. Thank you to our panelists for your expertise and your leadership. And thank you to all of you across the Commonwealth who care deeply about building a future where aging and dignity is not a privilege, but a shared promise. Now I'd like to turn it over to my colleague, Dr. Kiame Mahanya. Dr. Mahanya serves as Undersecretary for Health and Human Services at the Massachusetts Executive Office of Health and Human Services. Kiame, please turn on your camera and microphone and take it away. Thank you.
Thank you, Secretary Lipson, and thank you all for joining us today. I'm honored to be here for this important dialogue. One of Massachusetts Executive Office of Health and Human Services' strategic priorities is preparing for the profound demographic shift already underway, the aging of our population. Today, 1.7 million adults over the age of 60 call Massachusetts home, nearly a quarter of our population. In 2010, there are more people under the age of 20 than over the age of 60. Today, those numbers are flipped. And projections for 2040 indicate that these population shifts will continue to deepen. Our older population now spans 5 decades, ranging from people under 60s to people who have reached 100 years and beyond. This aging trend brings with it tremendous opportunities. Older adults contribute deeply to our communities, our economy, and our families. Many serve as important community and civic leaders, volunteers, and mentors, enriching our community with their life experience and expertise. Over 20% of Massachusetts adults age 65 and older engaged in volunteer activities, and a growing number of older adults are working longer, adding an incredible wealth of knowledge and experience to the Massachusetts economy well past the age of 65. But this shift also brings serious responsibilities. Chief among them is ensuring that we have the infrastructure, physical, financial, human, to meet their health and long-term care needs in a way that is equitable, accessible, and sustainable. We know that most people want to age in their own homes and communities, and we are committed to supporting them in doing that. But we also know that the current long-term care system too often places that responsibility squarely on families and on unpaid caregivers and on individuals who spend down their savings just to qualify for help. That's not a system that's built for the future. That is why Senator Pat Jelen and Representative Tom Stanley, who we will hear from later today, directed us to contract an independent actuarial study to examine the feasibility of public and private options to help individuals prepare to meet their LTSS needs through an amendment to the FY24 budget. We contracted with Milliman, a leading actuarial and consulting firm with extensive experience in long-term care, to 1, conduct an independent analysis of public and private long-term care financing programs in the Commonwealth, and 2, create a model to assess the costs, benefits, and impacts of potential public financing options funded through a payroll deduction. Today's webinar is the culmination of this work, but it is really just the beginning. This is about more than just financing models. It's about building the foundation for a system that supports choice, independence, and dignity for every Massachusetts resident as they age. And that requires bold thinking, cross-sector collaboration, and a shared commitment to act with urgency. We are fully committed to leading this work in partnership with all of you. The Healy-Driscoll administration sees this as a defining challenge for Massachusetts. Thank you again for being here and for being part of this essential conversation. And now, I will turn it over to Mark Cohen, Professor of Gerontology and co-director of the Leading Age LTSS Center at UMass Boston. Mark, please turn on your camera and microphone. The stage is yours.
Thank you so much. I'm so delighted to be here. Relatively small task of explaining why this is so important and what long-term care actually means. The fact of the matter is, and I think Secretary Lipson said this very well, we should care about long-term care because most of us will actually end up needing services due to population aging, increases in longevity. The services cost a lot of money, and most people can't actually afford them today. And there's not yet really an efficient way to pay for this care. It actually represents the largest unfunded liability facing families during retirement, which means that it undermines individuals' preparedness for retirement. And it also represents one of the fastest growing components of state budgets because Medicaid, Mass Health, is the largest public payer of long-term services and supports. Now, just to level set, I want to remind people that these services are generally non-medical supportive services designed to assist people who have difficulty performing basic living activities. And the services are primarily provided in one of three settings. There's home settings, where, by the way, 3/4 of people with long-term services and supports needs live. There's residential or institutional settings like nursing homes, and there are a variety of community-based settings. Another feature of long-term services and support that's so unique is that they are provided primarily by family members, adult children, spouses, as well as paid caregivers like home health aides, homemakers, and companions. And so these are really palliative in nature. They're not curative in nature. Paid and unpaid services are close substitutes for one another, and family caregivers provide the bulk of the care. Secretary Lipson mentioned this. The distribution of need varies widely. So if you take someone over age 65, it turns out that about half the population may not actually have any need at all or minimum need. A quarter may end up needing care from family or paid sources for under 2 years, but another 15% need services for actually quite a while, more than 5 years. And if you have to pay for this care, it costs a lot. Just to give you an example, home health aides can cost upwards of $77,000 a year if you need them on a full-time basis. Assisted living costs roughly $70,000 a year. And if you need nursing home care, we're talking about over $110,000. So the lifetime expected costs that someone can incur if they have a need are pretty significant. So you may ask, well, how does this actually get paid for? There are three major sources of long-term care. One is the major public program, Mass Health, Medicaid, which is actually the default program, pays about 60% of costs. Older adults and families make up the next largest payer of care, and private long-term care insurance typically pays for about less than 10% of the nation's long-term care bill. Now, very quickly, what are the challenges with Medicaid financing? It's actually the default. When people have long-term care needs and expenses, they will spend their income and assets often, or they won't have them. And Medicaid, Mass Health, represents the social safety net program. So you have to spend down those resources and become eligible for the program. A lot of times there are waiting lists for services. There's less flexibility in service provision. And states are really struggling because it's one of the fastest growing budgetary items. What about long-term care insurance? Well, the fact is that the long-term care insurance market has underperformed initial expectations. Sales have been declining. Not many companies are providing services any longer. And fewer than 10 million people have policies. For people who have them, they're of course of great benefit. But today, there are less than a dozen companies that are really selling meaningful long-term care. So where does that leave us? It means the current system leaves most families paying out of pocket when the need strikes. And as I said, it's paying a lot out of pocket. The fact is, many families struggle. I mean, if you just look at how much people have saved in their retirement plans, it can be less than $10,000. When it comes to Mass Health, as good as the system is, there's still fragmentation. It's means tested. and we don't have the broad-based financial solution. So why are states interested in LTSS form? And with this, I'll close. The main reason is that the costs of waiting to do nothing and just let the system unfold are starting to exceed the costs of taking action. And so what you see is more states are starting to think about shared or communal approaches, especially as there's gridlock at the federal level. States have been left holding the bag. And I think for that reason, the culmination of these factors coming together is what's primarily responsible for why Massachusetts has taken the far-sighted decision to engage the actuarial study. And so with that, I will turn it over to our Milliman team to talk about this study and how what they're finding is going to start to address some of the issues that I've raised.
Great. Thank you so much, Mark. Good afternoon, everyone. I'm Annie Gunlickson, Consulting Actuary with Milliman, and today I'm joined by my colleagues Chris Giese, Evan Pollack, and Sam Smedick, and we're really excited to talk to you today about the LTSS feasibility study. To be honest, we could spend hours presenting all of the findings, methodology, assumptions that are detailed in our report, but we have about 30 minutes. So today we're going to focus on background on the study, background on LTSS financing as it exists today, and then highlight some of the findings on the public program modeling that we included in our report. I know we mentioned this already during the presentation, but as we go, feel free to post questions in the Q&A feature. We'll try to monitor these during our presentation and answer things as we can, or via the panel discussion after our presentation. So with that, I'm actually going to pass it over to my colleague Sam, who is going to share more background information on the study and LTSS financing.
Thanks, Annie. We can move to the next slide. So as Annie said, we're going to start off with a brief background of our actuarial study. So just going to give a brief introduction of who Milliman is, the components of the study, and then just kind of the timeline and general stakeholder engagement that was a result of this study. So if you could go to the next slide. So Milliman is a global actuarial consulting firm. We have over 25 years of subject matter experience in both the public and private payers in managing long-term care risk. We consult with many major long-term care insurance carriers, as well as some public entities, notably the state of Washington and the Washington Cares Fund. We'll hear a little bit more about that later in the panel discussion as well. So we acutely understand both long-term care insurance and finance and reform, as we have over 20 senior actuaries and consultants focused on long-term care, which is the largest expertise of any consulting firm. We can move to the next slide. So just wanted to provide some brief background on the study. So there's really three components to it. The first is the evaluation of the status quo, and that was really an analysis of both the public and private long-term care financing options that exist in the state of Massachusetts today. So really looking at the aging population and kind of the costs associated with care. The majority of our report focused on public program modeling, and we modeled three kind of main programs through a payroll deduction, and that was a front-end limited benefit duration program, a back-end limited benefit duration program, and a back-end unlimited benefit duration program. And we just wanted to mention that these were really informed by discussions with both the state and stakeholders that we talked throughout kind of our process of this modeling. We also wanted to mention we did model a number of alternatives as well, apart from these three main programs, and Annie will kind of get into more of that modeling a little bit later. The last phase of our report was looking at tax and other incentives for the purchase of private long-term care insurance. And this was kind of a brief section at the end of our report that Annie will also talk about later. So we can move to the next slide. So this was kind of the timeline that we undertook when conducting this feasibility study. And the main thing we wanted to point out here is that we kind of talked with stakeholders at various points throughout this study. Before we began kind of analyzing everything, we gave a brief overview to stakeholders kind of on what long-term care insurance is and the importance of why that may be needed in the state of Massachusetts. Before we kind of conducted the analysis, we then met with stakeholders individually and in small groups to kind of discuss the goals and the priorities that each of these stakeholders might have. So these stakeholders included a variety of entities, representatives of government, public advocacy groups, consumer groups, private insurers, et cetera. We then met with them again after we began modeling a report just to kind of present initial findings and to get feedback on things that may be important to the stakeholders as we work to finalize the report. And then at the end of our study, we met with stakeholders again just to present our final findings and get reactions to our final results as well. So with that, we can move to the next slide. So kind of going back to the three components of our study, the first component was the evaluation of the status quo. And kind of two important things we wanted to bring up here was defining long-term care and then kind of just summarizing the cost, demand, and the payers of long-term care insurance. So we can move to the next slide. So briefly defining long-term care, I think Mark did a great job of kind of summarizing this. It really is for services and supports for individuals who need assistance with the activities of daily living. So just a few examples of that include eating, bathing, dressing, toileting, mobility. And this type of assistance is often needed by people who are aging, although we did want to mention that there is a disabled population who may be younger who are also eligible for some of these long-term services and supports. As Mark also mentioned, this care may take place in institutional settings or in home and community-based settings as well. And just one note for the rest of this presentation is that we may use long-term care and long-term services and supports interchangeably throughout this presentation. So if we can move to the next slide. So these three graphs kind of really summarize three of the key findings we had when evaluating the status quo in the state of Massachusetts. So on the far left, that is the projected percentage of population age 65 plus, both nationwide and in Massachusetts. As you can see, in 2020, we're around 18% or so, and that's going to increase well over 22% by 2050, and it's only projected to grow from there. Massachusetts does have a slightly higher population that is older than the rest of the United States. So again, just another emphasis on why long-term care service and supports may be needed in the future. Additionally, kind of going back to Mark's comments, the care is very expensive for a lot of places where you might need long-term care services. So the bar graph at the bottom there shows the average median cost of long-term care in skilled nursing facilities, assisted living facilities, and home health care settings for both nationwide and in Massachusetts. So skilled nursing facilities cost a median amount of over $150,000 annually, which is very expensive. And assisted living facility and home health care are a little bit over $50,000 as well. In all three of these settings, the median cost of care in Massachusetts is greater than the average nationwide. And then lastly, again, kind of echoing Mark's comments, just looking at the percentage of costs that are covered by certain payers. Medicaid by far is the largest payer of long-term care services currently, with over 50% of the costs being funded through Medicaid. Next is kind of the other bucket and out-of-pocket and private insurance as well, taking up about 10%. A lot of individuals may spend down their assets and then eventually qualify for Medicaid as well. So that also makes up a portion of the Medicaid expenditures as well. One other thing that this does not really capture is unpaid caregivers as well. So although this is kind of the spending of individuals for long-term care services and supports, it's also important to understand that there may be families of individuals who are taking care of their loved ones as they kind of go through the aging process that may not be captured in this graph. So that was just kind of a brief overview of what our analysis of the status quo kind of told us about the state of Massachusetts long-term care financing. And with that, we moved into kind of some public program modeling. So I'll turn that over to Annie and we can go to the next slide.
Great, thank you, Sam. As Sam mentioned, I'm going to now walk through some of the highlights from our public program modeling, which really form the bulk of our analysis. So we can go on to the next slide. Before we get into the details and results for our public program modeling, I just first wanted to ground us in generally what this program could look like. So for our study, we assumed that the program would be financed through a flat payroll tax, and that to be eligible for benefits, individuals would have to pay the tax for a specified number of years, which we referred to as the vesting period. Then individuals who had vested would be eligible to draw benefits once it was determined that they were benefit eligible. On this slide, we have an example of that they would need assistance with 2 or more activities of daily living or are cognitively impaired to become benefit eligible, but that is one of the program parameters that we modeled variations of in our modeling. Beyond that, we assumed that benefits would begin for individuals following an elimination period, or essentially a deductible period, which would be the period of time between the onset of frailty and the start of benefits. And during that time, it would be assumed that individuals would pay for costs out of pocket or by other payers. And then lastly, the benefits would be paid until the total benefit maximum was reached, or in other words, an individual's benefit pool was depleted. So now we can move on to the next slide where we'll talk about some basics in terms of a funding structure. So I already mentioned that we assumed that the program would be modeled through a flat payroll tax. We modeled the full tax rate, but in practice, that could be split between an employer portion and an employee portion. And to calculate the required payroll tax, we assumed that the program would follow a pay-as-you-go structure. And we performed our modeling over a 75-year time horizon, which you can see on the graph on the right on this slide. And we calculated the required payroll tax such that the present value of program revenue is essentially equal to the present value of projected program outgo. And we also verified that the program fund would always be sufficient to pay the following year's program outgo. So with that, we can move on to the next slide. So as Sam mentioned, the task order for this study prescribed that we would model 3 plan designs: a front end, back end, and catastrophic design. In total, we modeled over 200 plan variations, but in order to understand the incremental impact of different plan parameters, we established these 3 core plans that followed kind of those 3 structures that were laid out in the task order. So the first of which is a front end design, the front end limited duration program. You can see that for the core plan, we assumed that that plan would have a total benefit of $75,000 and that individuals would be eligible for that benefit after a 30-day elimination period. So this is a relatively shorter elimination period and a relatively limited benefit compared to some of the other designs that we modeled. And those parameters resulted in a required payroll tax of 0.68% for that design. The next core plan design that we modeled was a back-end design. So this plan design had a longer elimination period than the front-end design. So 2 years that individuals would have to wait before being eligible for benefits. But at that point, they would be eligible for a larger total benefit of $150,000. So fewer individuals would be able to access the benefit since the elimination period is longer, but for the individuals that would become eligible for the benefit, they would have access to a larger pool of money. These program parameters resulted in a larger required payroll tax of 0.88%. And then lastly, we modeled a catastrophic design, which would be have a longer elimination period. Individuals would have to be on claim for 3 years before they would receive a benefit from the program. But once they made it to that 3-year period, they would have access to an unlimited benefit. And that program design resulted in a 2.74% required payroll tax. The last line of the graph or of the table on this slide, you can see all of those payroll taxes shown in a dollar equivalent. So for an individual who would be making $75,000 a year, that would mean a $42 monthly tax, $55 monthly tax, and a $171 monthly tax for each of those payroll tax rates. So from there, we can move on to the next slide. Great, thank you. So within each of those 3 core plan designs, we modeled a number of different alternatives. Each dot on this slide represents an alternative that we modeled just relative to the front end benefit design, but we modeled our alternatives relative to the front end, back end, and catastrophic design. And hopefully what you can see on this slide is that within just those front end designs, we see a large variation in results. The lowest tax rate around a 0.4% and the highest above 2%. So really indicating that changing different benefit parameters has a really large impact on the required payroll tax rate. Over the next few slides, I'm going to show some examples of the different alternatives that we modeled that really relate to the words kind of on the left of this graph that show all of the different benefit parameters that are considered when thinking about the ultimate benefit design for a program. And the goal of sharing these results today is really to help, well, not today, the goal of sharing these results in the report is to help understand the financial trade-offs of different program parameters to ultimately help inform what plan design could look like and what the financial ramifications of that plan design could be. So with that, we can move into the next slide and talk about an example of one of these types of alternative designs. I guess maybe I just want to caveat this before I get into this slide. I know there's a table with a lot of numbers here. For the purposes of today, I want to focus less on the exact numbers in this table and more on conceptually for each of these program parameters, what is driving the results up or down. So the first alternative that we wanted to talk through is a total benefit alternative. And what we're getting at here is from that first slide that showed the total benefit for each of the plan designs. How does changing that amount change the required payroll tax? So you can see here that the core plan design was a $75,000 benefit. We modeled alternatives that were lower and higher than that amount. And generally speaking, increasing the total benefit available increases the expected benefits paid and also increases the required payroll tax. So hopefully you can see that on the table shown. Maybe one thing to note also on this slide is that beyond a total benefit maximum, the program we assume would also be subject to a monthly benefit maximum. And when we conducted these alternatives that impacted the total pool of money that an individual would have access to, we kept constant that monthly benefit maximum so that regardless of how the total pool shifted, the total benefit maximum would remain constant at $7,500 per month. We can move on to the next slide now and talk about another alternative design that we modeled. For our core plan designs, we assumed that the benefit would inflate by 3% annually. We modeled alternatives that considered other benefit inflation amounts lower and higher than that 3%. And you can see here that increasing the benefit inflation increases the expected benefits over time and therefore increases the required payroll tax rate. Something to consider in terms of benefit inflation and why this is important for a public program is that benefit inflation allows the program to keep up with the cost of care trends that impact long-term care. So the amount of benefit inflation relative to the cost of care trends that occur really impacts the purchasing power of the benefit over time. So for example, if the cost of care trends exceed the benefit inflation, the purchasing power to consumers of the benefit of a potential public program could decrease over time. So with that, we can move on to another example on the next slide. So another example that we considered is covered services. So for our core plans, we assumed that a public program would cover services both in a facility and at home, but we modeled alternatives where this might not be the case. For example, and maybe just to level set, increasing the types of services that would be covered increases the expected benefit payments and would increase the required payroll tax. One thing to note here is that the covered services, changing them, doesn't actually change the total benefit available to consumers or the monthly benefit available, but would impact the number of beneficiaries who are expected to receive benefits and would also impact the cost of the benefits that we would expect individuals would be reimbursed for. And those things are what would increase the expected benefit payments. So you can see examples here. We modeled one example where only home care and non-institutional care was covered. And since fewer covered services are available, the tax rate would decrease. And then on the flip side, we modeled another alternative where in addition to facility and home care, we assumed that informal caregivers could also be reimbursed, which would increase costs for the program. With that, I think we can move on, and we have one more example of the type of alternatives that we modeled, and this is related to portability. So portability considers if benefits would be allowed to retain their benefits if they moved out of state. For our core plans, we assumed that a program would not have any portability, meaning that they would no longer be eligible to receive benefits from the program if they moved out of state, even if they had attained that required vesting period. But we modeled two different alternatives where we assumed that there would be full benefit portability. As you can see, in adding portability to the program would allow more individuals to access the benefit, which would increase costs to the program and therefore increase the required payroll tax. Something to think about for this particular benefit is we assumed that a portable benefit could be voluntary, meaning that if an individual moved out of state, they would have the option as to whether they wanted to retain their benefit or not. And what we modeled was that if they chose to retain their benefit, they could continue paying a payroll tax. And that continued contribution would mean that they would be eligible to receive a benefit. Anytime we model voluntary situations, that creates a situation where the program could experience adverse selection. And we anticipate that this type of benefit could experience significant adverse selection because individuals who would be vested and have little to no remaining wages or no additional payroll taxes might be inclined to participate in the program, which would really just add costs or add benefits to be paid without actually adding additional revenue to the program. So you can see here that for those two alternatives, we assume different participation scenarios to model what potential costs could be under different participation scenarios. With that, we can move on to the next slide. This slide really just shows a table of all of the different alternatives that we ran. We didn't have time today to walk through all of the different program parameters that contribute to a benefit design, But some of those are shown on this table, and all of the results are included in our report. So with that, we can move on to the next slide. Great. So while we modeled all of these different tax rates, something that we stress multiple times throughout our report is that the purpose of our study is to assess feasibility, not to price a program or to set a program tax rate. To set a program tax rate, beyond the modeling that we've performed already, additional modeling would need to be done, specifically considering the concept of margin or cushion. And to appropriately determine margin, it would be really important to understand the major sources of uncertainty that could impact the future program results. We do some of this in our report, and that's considering how actual experience might deviate from the assumptions that we modeled in our core modeling. So when we think of uncertainty, something that we typically turn to is sensitivity testing. So we modeled a range of sensitivity tests in our work on the underlying assumptions that we used. And if you go to the next slide, you can see that what we found is that the sensitivity of the payroll tax rates are very, very sensitive to the underlying assumptions that we assume. So this graph shows the different tax rates by some of the different assumptions that we sensitivity tested. And you can see that the financial outcomes are highly sensitive to the different assumptions. The sensitivity of payroll tax results under different conditions, as well as the program's ability to adjust features when the experience materializes differently from expectations, are vital components for the monitoring of an LTSS program. So that would be something that would be really important to continue to study and monitor as a public program is considered further. So with that, we can move on to the next slide. Sam mentioned at the beginning of this presentation that beyond the public program modeling, we did conduct additional analysis as well. And this next slide, if we go to the next slide, talks a little bit about this additional analysis. We don't have time to get into all of these items today, but just wanted to give you a preview of some of the additional analysis that's included in our report. The first additional analysis we performed was considering the long-term care actuarial value for a number of the alternatives that we modeled. And the long-term care actuarial value, the goal of that is to quantify how much coverage a particular insurance benefit provides versus the amount remaining that would need to be covered by other sources. So this metric can be really useful to help consumers understand the value of the benefit, and also the remaining expected costs that would need to be covered by other sources. This is a helpful metric to compare programs to each other beyond just comparing the payroll taxes. And this metric also varies not just by plan design, but also by beneficiary characteristics. So what the expected claim age, gender, and projection year are for individuals. And you can see how the value of the benefit might vary by those characteristics as well. So we present a number of different long-term care actuarial value metrics in our report that can be used to understand how plan designs might impact different residents of Massachusetts differently. Another thing that we studied was the impact to the Medicaid program. So as we've talked about already today, Medicaid is generally the payer of last resort for healthcare services. So if a public program, such as the one we've discussed, provided an LTSS benefit that would provided services that would normally be paid for by Medicaid, then Medicaid expenditures might be reduced as a result. As part of our report, we estimated potential savings to the Medicaid program that could result from a state-based public program being introduced in Massachusetts. And lastly, this was one of the pillars that Sam talked about. We also were asked to consider private market incentives or tax or other incentives that could increase participation in the private long-term care insurance market. This is something that we discussed a lot with different stakeholders and include an appendix in our report that goes over some of the feedback that we heard from stakeholders. One of the main things that came out of that analysis and those discussions was really the idea that financing LTSS is complex and will need a multifaceted approach. So a public program, and you can see this in our long-term care actuarial value results, a public program is none of the alternatives that we modeled cover 100% of expected long-term care costs. And it's also potentially unlikely that the private market can cover 100% of the state's long-term care actuarial costs. But perhaps there could be a solution that could combine different payers using a multifaceted approach, integrating private market solutions, state-based programs, and other initiatives to create a comprehensive solution for the state of Massachusetts. So with that, I think we can move on to the next slide, which is just the end of our prepared remarks. So with that, I think that I'm going to pass it over to Caitlin, who is going to lead us off in our panel discussion.
Andy, I think before we do that, I think we have maybe a couple minutes to.
Oh, yeah.
Certainly. I don't think we can get to all these, but maybe we can try and address a few of these questions. Caitlin, if that's okay, I think we have a couple minutes. Right.
Perfect.
All right, in no particular order as they came in. I was kind of looking at these as they came in, Andy. So
Wonderful, thank you.
One question is around the structure of the elimination period and when that starts. The way we modeled it is what would be commonly referred to as a calendar day EP, which for all intents and purposes means that once an individual meets the benefit eligibility criteria, the days start counting toward the elimination period, regardless of whether they're receiving services or not. So it used that calendar day definition. There was a question around how did we project kind of the payroll tax in the future, looking at perhaps changes in the workforce. Definitely would recommend taking a look at the report. A lot more details on our methodology and assumptions in there. One of the primary sources that we start from is the Social Security Trustees report, which will have projections of kind of trends in future wage growth, changes in the workforce. So we use that as a starting point, and then to the extent available, kind of customize that to characteristics in the Commonwealth. So hopefully the details in the report, will give a little bit more insight in how we project that out over the next 75 years. There were a couple questions around the elder home care program. That was not, a large focus of our study. We did not look at the impact of that program at all, but we do cover that a little bit in the status quo in our full report. I think there was a question which maybe was semi-answered already around what is the benefit on a daily or monthly basis. For our core plans, that was a $7,500 monthly benefit. But in the report, we also tested different variations of what that monthly benefit would be as well. I think that is most of the questions. I think Andy covered this a little bit around portability. So the base core modeling that we looked at did not include portability. We did assume that if individuals were living out of state but working in Massachusetts, that they could be exempted from the program. But going kind of the other way, if somebody worked in Massachusetts their whole life and then left, the core designs do not include a portable benefit under that modeling structure. I think there was a question around, how would that look if you did offer a portability benefit, and how would individuals continue to pay for that? I think there's a lot of different ways you can think about structuring that. Kind of high level, the approach we took borrows a little bit of, I think, what you'll see as part of the WA Care funds, where when individuals live out of state, they would still have some responsibility for reporting their earned wages, and then the payroll tax would still get applied to their earned wages even as they live out of state. I think that was, there was one question around, maybe the last question just came in around pay-as-you-go finance solution versus some pre-funding. The graph that Annie had put up, hopefully gave a little bit of insight into, maybe the way to describe this as kind of pay as you go with some pre-funding, due to primarily, the vesting requirements under the program. What will end up happening is in the early years of the program, more premium taxes will be collected than needed, versus the expenses that are going out the door. So there is some elements of pre-funding, where then those funds would be invested to then help pay for future obligations down the road in that 75-year window. So that's all. Hopefully you'll find all that detail available in the report as well to help answer some of those questions. So I think that maybe uses up our 5 minutes to kind of get through. Apologize for the questions that we did not get to. I think we were able to touch on quite a few of them. So Caitlin, I'll turn it back over to you.
Fantastic. I want to thank the Milliman team for their comprehensive and robust analysis. And also thank you for presenting these findings in a way that those of us that are not actuaries can actually understand them. I'd like to welcome our panelists to this discussion. We have with us Ben Vecti. Ben is the director of the WA Cares Fund in Washington State, the nation's first universal long-term care insurance program. We also have with us Lynn White, the president and CEO of Care Scout Insurance. In addition, we have Aaron Bateman, who is an expert policy consultant and the former CFO at the Massachusetts Executive Office for Aging and Independence. And I believe Chris Giese from the Milliman team may join us as well at certain points. Here he is for this conversation. I won't provide extensive bios for all of our panelists. They are included in the registration materials for those of you who are interested in learning more. But I will say we have a very esteemed group of panelists before you all with diverse expertise and experience on this topic. So I think we'll have a great conversation ahead. So I first just want to say I'm thrilled that we're here and we're having this conversation. I come to you from the Blue Cross Blue Shield of Massachusetts Foundation, where I'm the Vice President for Policy and Research. Back in 2022, Massachusetts was in an election year. We had a gubernatorial election. We had some open elections in our legislature. And at that time, our foundation commissioned some research saying, what are the key issues? What should be the the most important priorities for the next administration? And as part of that work, the issue of needing to identify a more sustainable approach for financing equitable and affordable access to long-term care and long-term services and supports surfaced. And so it is really wonderful to see that we have really galvanized attention to that issue and moved forward with a critical first step in this discussion. I think, just to reiterate some of the points that Mark made, we know that equitable access to long-term services and supports is a continued challenge, that Medicare does not robustly and comprehensively cover these services for prolonged period of time. Neither does commercial health insurance, and often people need to rely on Medicaid, which means spending down assets and personal expenses. Few people have the personal resources to directly pay for these services. And there are not yet many people who've purchased long-term care insurance programs. So I think the main takeaway before I pivot to my panel is there must be a better approach to meeting the long-term services and supports needs of the Commonwealth. And I'd love to sort of spend our time today thinking about what that might look like and what the next steps in the journey should be for Massachusetts. So Aaron, I'm going to first turn it over to you. Um, Mark set us up a little bit, but he had 5 minutes. And I think it's important just to reiterate, can you tell us a little bit more about why this is so huge? Why the issue of needing to think about a system for long-term services and supports is critical in Massachusetts? And the Milliman team sort of set some context on the Massachusetts population, but if you could really sort of drill down like why this is critical right now in Massachusetts, that would be a really helpful starting point for us.
Thank you, Caitlin. And before I respond, I would first like to say thank you to everyone who made this actuarial study possible and to all the people who have taken time today to join this webinar. This is a really exciting moment, and I'm grateful for the opportunity to be here. So, this question of why is long-term care finance reform needed in Massachusetts? Echoing points that that folks have made previously, most people in Massachusetts lack a form of long-term care insurance, which means that there is a significant long-term care cost coverage gap for people in the Commonwealth. Another point that has been made previously is that long-term care costs can be high. These can range from over $50,000 at an assisted living residence or for home care to more than $150,000 at a skilled nursing facility in the state. And many people over the age of 65 are likely to need long-term care because of functional ability challenges due to aging or increases in longevity. But why social insurance in particular? Well, a public long-term care social insurance program spreads long-term care cost risk across a society and puts long-term care firmly on the policy agenda. With such a program, many individuals and families in Massachusetts would not have to cover long-term care costs alone. By bearing a portion of long-term care costs that individuals and their families must otherwise cover, a public long-term care social insurance program enables people who would otherwise need to be providing care to their loved ones at home to enter or re-enter the workforce, thereby creating opportunities for both workers and employees. Investing in long-term care through a public social insurance program also creates opportunities in related sectors of the economy, which can contribute overall to the state's economic productivity and output. Why now? Why is now the time for long-term care finance reform in Massachusetts? There was a great graph showed by Milliman that I'll refer to. The 65 plus population in Massachusetts in 2010 was 14% of the total population. And in 2035, the 65 plus population is projected to be about 23% of the total population. So about a 10% increase in 25 years. Because passing and implementing legislation will take time, to have a reformed long-term care system in place by 2035 to meet expected long-term care services and supports demand means that time is of the essence. Thank you, Caitlin.
Thanks, Aaron. And I think, some of your comments really make me want to talk a little bit, Ben. I think it'd be helpful to hear from you. You spoke, Aaron, about this is urgent. And part of the reason that this is urgent is because this will take time. And I think Ben can speak to, Washington State's further ahead of us in Massachusetts. I know that's hard for those of us in Massachusetts to hear. We like to always be the leader. But in this particular instance, Washington State is ahead of us. And I think, you're sort of 10 years ahead of us in some ways, having first started this conversation in 2014 and in 2019 establishing the WA Cares Fund. So I think it would be helpful, Ben, if you could talk a little bit for us about sort of your initial experience. We'll come back to some of these themes later on in our discussion, but what were some of the initial challenges that you experienced? What went well, what didn't? And as we think about sort of positioning ourselves to be on that journey, as Erin was describing, what are some pieces of feedback you'd have for us in terms of how to make sure that we stay on the trajectory to having a social insurance program in place?
Thank you so much, Caitlin, and thank you for inviting me to participate in this important webinar today. Great questions, and thank you to Milliman for the actuarial work. The actuarial work is critical, and the actuarial dimension of any program design is critical, and we'll talk about that more throughout the webinar. But to answer your questions, I think there's some other lessons that are also important from Washington State, and I'll touch upon them briefly. There were really 4 elements that were critical to the success we've had in Washington State. The first is having a strong stakeholder coalition and robust outreach. What you need for a program like this to succeed is a paradigm shift. To support a paradigm shift in awareness, both in the public, that already today individuals are suffering harm as they age without support, and today already families are having their financial security undermined. But also that with the age wave transpiring, in our state alone, the population 85 and older is quadrupling between 2025 and 2050, which means that as bad as things are today, they're going to get 4 times worse, or 4 times as many families are going to be affected by this. And so the problem's only getting worse. You need to raise awareness through the coalition and outreach for 3 reasons. The first is that people tend to focus on their immediate needs, not long-term ones. And for obvious reasons, there's, cost of living is high, people are struggling to pay their bills. Secondly, most of us are in denial about ever getting old, much less needing long-term care. That's a particularly American problem. In most Asian countries and European countries don't have that problem nearly as much as we do, but we tend to, that's another reason why the private insurance sector as a whole has struggled, because people don't think they're going to need long-term care. And third, people tend to view their struggles coping with family long-term care needs as a personal failing, not something that we could address together as a community. We all feel we should be doing more for our parents as they're going through this, and we feel bad about it and feel guilty about it without really realizing that we could have a shared solution. So you need a strong coalition of civil societal groups like we had in Washington. In our state, we had about 20 organizations in a coalition that worked together to do that, affect that paradigm shift. And ideally, you need a funded, dedicated position to lead that coalition, a person that's not funded by a particular stakeholder but stands above the coalition. That could be funded by philanthropy or by the government. But there's many times when the journey you can get off course on the journey towards enacting a program like this, or once it's enacted towards the program succeeding. And it's important to have strong guidance from a leader of that coalition. Second, it's essential to honor the principle that whoever pays in to the program must be able to claim benefits. The program has to be designed as a premium, as an insurance program, not just as a tax, because people are skeptical of taxes. They're skeptical of the fact that money is fungible in the general fund. And so it's important that you design the program that way. And we had to fix that in our state. We had some errors in our original program design. The biggest one there was around portability, where people who paid in and then left the state couldn't claim in other states. We fixed that in 2024, where we're making benefits available nationwide, and even we're trying to make it possible for people to claim benefits internationally. And that's, I think, an essential component of program design. And then third, you need strong leadership from the commission and the program director to keep it on course. There have been about a dozen times over the last 5 years when this program could have been derailed. Some relate to adverse selection, which is an actuarial challenge. Some relate to provisions that would have undermined public support. Some relate to administrative implementation choices. The experience of the Class Act, which was part of the Affordable Care Act, which was a long-term care insurance program as part of the Affordable Care Act, shows what can go wrong. That program was poorly designed because there was no strong leadership behind it. It was a lot of advocates on the one hand and lobbyists on the other hand, kind of co-designed the program in a way that you ended up with something that was actuarially unsustainable. And so the program had to be repealed before it was ever implemented, the Class Act. And so That lesson shows us how important strong leadership from the coalition, the commission, and the program director are to make sure that the program doesn't get actuarially derailed. And then finally, you need to be strong in your messaging that just because a public program doesn't address 100% of everyone's long-term care needs, that doesn't mean it's not worth doing. So something is better than nothing, and you have to start somewhere. As Mark said at the outset, long-term care is the biggest unfunded liability for most people in retirement. And we found that initially, when Walk Cares was rolled out, many people didn't support Walk Cares because they essentially blamed Walk Cares for the existence of the long-term care financing challenge altogether, because they never really thought about it before, and we were kind of obliging them to think about it. And then they got it, once they started thinking about it, they were upset that we didn't completely solve the entire problem. Of course, people didn't support having a very large premium for a benefit that would solve the entire problem. They have that in the Netherlands, for example. But most Americans don't want to have a really high premium for a comprehensive benefit. And so it's really important to message from the start that even though the program may not solve 100% of everyone's long-term care needs, something is better than nothing.
Thanks, Ben. Really, really helpful to get your insights as someone who has experience in this space and can guide us along the way. I want to turn to Chris, in part because you mentioned at the outset of your remarks the importance of stakeholder engagement in hearing from the community and hearing from the community across a wide range of sectors. Chris, I know as part of the Milliman work, you outlined that there was stakeholder engagement all along the way at different points in time in this work. And I think what I'm hearing from Ben is that's critical. And then moving forward, it's critical to continue to ensure that we're engaging with a variety of stakeholders. I'm wondering if there's any key themes, key messages that you heard as part of that stakeholder engagement process that is important for us to remember and to consider as part of our effort to continue to ensure there's attention to this dialogue and a broad base of support for considering the options that might work in Massachusetts.
Yeah, we've kind of been through kind of this stakeholder engagement process for a handful of states now. We helped participate with Washington State back in 2015, 2016 as part of that process. So definitely a really key part of the journey to kind of build that coalition and support, as Ben was mentioning. When we think about kind of the stakeholder engagement we did as part of this project, maybe unsurprisingly, there was a diversity of opinions. This is a really complex problem, and there's a lot of different ideas around how to solve it. Even among groups where you would think everybody would have the same opinion, the opinions even vary, within sectors within this space. So really complex, a lot of diverse opinions and ideas around, what solutions should be. So before you kind of get into the messiness of, what are those, areas of disagreement, I think sometimes it's good to get grounded around where do we agree. So I think there are some areas of consensus that definitely came through as themes as part of that. One, and this has been touched on already, just the lack of knowledge and awareness around the issue and the costs, and where do I turn when I need help. It's a really emotional time when you no longer can care for yourself, or your parent or loved one can no longer care for yourself. It's a very emotional, stressful time. Where do you go? And just the lack of awareness and education, I think, continues to be a really big point that people have identified. I think this has been touched on a little bit as well, but given just the size and magnitude of this problem, this is not going to be solved by one sector. This isn't just a public problem. This isn't just a private sector problem. There needs to be, a solution here that leverages kind of the best of each of those sectors and does it in a way where it's sustainable. You can't have the private market be successful at the expense of the government program, and vice versa. The government's program can't be successful at the expense of the private market. So something that really works together and is sustainable over the long run. And then lastly, and I think Aaron, you touched on this as well, is just that gap. what can we do? We have a system today, that exists, right? And does it exist as efficiently as it could? And what does that look like? And everybody's long-term care journey is a little bit different. Are there different ways we can provide options for individuals in a way that, is maybe more meaningful, a little bit more seamless in terms of, maybe I think all of us agree a little bit more of a fragmented system today that, maybe is difficult to navigate. So I would say those are some of the main themes. Where do we go from here? I would say, looking back at the lessons learned from Washington State, this is the time to be involved. Don't wait until, the law has been passed. I know Washington State was first, and, maybe it almost snuck up on people and they didn't realize the law and new program was going to be passed. But this is the time to have your voice heard. As you look at the full report, you'll see there's a lot of very challenging cost benefit trade-offs. And this is the time to kind of participate and have a voice as part of that.
Thanks, Chris. Really helpful to hear your sort of deeper dive on some of the insights learned through that stakeholder engagement process. I think one of the things I want to sort of tease out a little bit more that you mentioned was, and that also your colleague mentioned was, the importance of thinking about a multifaceted approach to the provision of ensuring people have access to long-term services and supports, right? Like not thinking about, oh, it's only a private system or only a public system, and not thinking about them competing against each other, but rather, thinking about how do we get these to work in partnership together? And Lynn and Ben, I think you both can probably offer some really helpful insights and perspectives here. So I'd love for you two to have a little bit of a dialogue here around, Ben, I think it would be helpful for you to tell us a little bit about, this presentation has largely focused on the analytic findings or actuarial findings pertaining to modeling a public option, a public social insurance program, which is sort of how things got started in Washington. But my understanding is that things have evolved and there's sort of a market now that includes, direct consideration of how long-term care can be offered through the private sector. And Lynn, I think if I'm right, Care Scout Insurance plays in that market. And so you probably have some really helpful feedback to offer us in terms of like how you think about and how we should be thinking about ensuring that private insurers are brought into that discussion and into the fold. So Ben, if you could just briefly talk a little bit about the evolution to get to where you're at now. And then Lynn, if you could talk a little bit about the experience in that market and sort of more generally how you think about, this partnership, that would be, I think, really helpful for us to hear from all of you.
Certainly. Ben?
Great. Yeah, great set of questions, Caitlin. We're the first state to do this, as has been mentioned. And so initially we had some stuff to iron out. I think inadvertently in our original statute, a situation was created which was counterproductive, where the public and private sector were sort of pitted against each other in this field, and that was not helpful because the private. I go to a lot of private insurance conferences and talk. We're all trying to solve the same problem, as Chris said, which is how do we protect families against this risk? And initially in our program, people could buy private insurance and opt out of the public program because they had bought private insurance. So what that led to was a period of time where brokers and carriers were marketing to people across our state saying, marketing against WACARES essentially to encourage people to buy private insurance. They would market against WACARES and as a kind of a tax strategy, right, to avoid the tax by buying this product. And a lot of people dropped the private product after they bought it, and so it didn't even help protect them at all. It just undermined the program, the public program. And so that kind of cannibalizing of the risk pool is very counterproductive from an actuarial perspective. It's called cherry picking, and it just means that the highest earners, the healthy high earners, end up buying private insurance to opt out. The public program is left, it becomes a high risk pool, which drives up premiums on the 85% of people who are left in the public program. That's not productive. And so we closed that loophole quickly. And then already over the last, we had 500,000 people out of 3.5 million workers opt out through that mechanism in the first year. we closed that loophole, and now there's only about 400,000 of those left in the workforce. And in about 15 years, there'll probably be less than 50,000 people, and the program becomes universal then over time. The future state of the program is that WalkCares it's not a public option. It is a front end, a public insurance benefit like Medicare, where you have Medicare and then you have Medicare supplemental. So we enacted this year the statutory framework for a supplemental private market where carriers can market and price coverage to Washingtonians that takes WalkCares as the deductible and offers coverage on top of it. This is a healthy relationship between the public and private sector. There's no competition between the two. We can together tell Washingtonians, look, this is a problem we all have to address. WalkCares addresses some of the risk, but it's not going to address all of the risk for most of you. So you really need more coverage. Here's some carriers that are offering private coverage that we encourage you to look at this because you're going to need more protection. It's kind of analogous to the retirement security space where you have Social Security, which provides a foundation of security for everyone. And then if people want more security, they save through the 401k or IRA system. It's the same thing, but in neither Medicare nor Social Security have opt-outs. High earners don't exempt themselves, can't buy a policy to exempt themselves from Medicare. They can't opt out of Social Security. It has to be a universal public program for it to work actuarially, but there is plenty of scope for, we only address the first 36.5 of risk, and the expected risk is much higher than that. And so we see a natural partnership with the private sector to offer coverage on top of that.
Sure. So, Caitlin, first of all, I say good afternoon to everyone, and I bring you greetings one Commonwealth to another. CareScout Insurance is headquartered in the Commonwealth of Virginia, and there are only a few of us, so I wanted to acknowledge that. And we are very grateful for the opportunity to participate in this discussion on behalf of the entire CareScout family of companies. We are excited about what is ahead and what opportunities lie ahead, and we are ready to engage. Now, you've heard so many people today talk about the need that exists. You've heard statistics and you've heard demographics, and it is very true that that need is just too great and the issue is just too complicated for one sector alone to address it. And so you have also heard the notion that we need participation across a spectrum of people, and I will note this spectrum of the long-term care services and supports ecosystem. It's not just insurance carriers, it's providers, consumer advocates, it's caregivers, it's members of the direct care workforce, government representatives, the business communities, families, and the like. So we need everybody engaged to help us with these solutions. But with respect to Washington state in particular, we have been focused on program sustainability and also middle market access. And with those thoughts in mind, CareScout Insurance hopes to partner with the state of Washington and any other state that is looking to implement a public program so that we can help to close some of these significant coverage gaps. And we are considering a supplemental offering that would wrap around the Washington Cares public benefit to ensure people have meaningful coverage. Now, there are some intricacies to work out because there are eligibility requirements for WalkCares that differ slightly from those that are normally applicable to private insurers. We have to work through those things, but we're committed to doing so. And not only that, our sister company, which is CareScout LLC, is actively engaged with the Washington State now with the intention of providing care access support and care navigation support. And our sister business has developed a network of providers, a national network of providers, and that have been vetted for quality and that also offer preferred pricing. So all of this will help in the construct of the delivery of care in this public-private context. And I wanted to note that at CareScout Insurance, one of the key components of our vision is that people can receive care in a manner that honors their humanity. And with public programs, we know that that can become a reality for a broader group of individuals. So we are prepared to do the hard work. Now, I wanted to note that advancing an initiative of this kind really will require attention and intention, and in many cases, compromise. There are interests that have to be balanced, and sometimes there are really hard choices that have to be made. So we want to ensure that we have an inclusive effort that will really leverage the collective expertise of us all to get to what is right, to what works, and what is sustainable.
Thanks, Lynn. I can feel the passion in your voice as you
Yes.
speak to this, which is really wonderful to hear. And I think hopefully invigorating for our audience here as well. And it's lovely, even on a panel, you can sort of feel this chemistry between you, Lynn, and Ben in terms of this shared commitment to make a public-private partnership work. So I would just say that's sort of a level of optimism and a spirit that's nice to bring to this webinar and to our audience today. You know, we've spoken
Caitlin,
on. Yes.
Caitlin, can I add just a sentence or two?
Absolutely.
Because
Please
Lynn
do.
and I could finish each other's sentences. But you know, there's middle class families. You know, the long-term care insurance industry was doing great in the end of the last century, and as Mark said, a lot of market factors have hurt the industry over the last 20 years, right? Interest rates, changes in interest rates, changes in longevity, things that nobody had predicted, it went differently than actuaries had expected. And I mean, that's also hurt our public programs in the country. And but as a result, today the broad middle class, a lot of the broad middle class can't afford private long-term care insurance, and the private insurance, so that hurts the middle class. And then the private insurance industry itself. And I'm not trying to speak for Lynn here; I'm speaking for myself. But the private long-term care insurance itself has had to focus most of its sales on higher earners because because that's the group that could afford the products. And what this new public supplemental private option creates an opportunity for is it's a win-win for the broad middle class and for insurance companies. I hope insurance companies enter this market because it's a vast market of people who could benefit from, who need long-term care insurance, could benefit from it. Maybe currently they can't afford it, but if a public program is covering the first tranche of risk, what that does is make it easier for carriers to price supplemental policies more affordably because they're not having to pay that first 36.5 or 50,000 or whatever your public benefit coverage amount is. They're not having to cover that first part of the risk, and so they're only covering risk on top of it up to whatever the face value of the policy is. And so it creates an opportunity for affordable private long-term care insurance coverage for the middle class for the first time since really the 1990s. I think obviously there have been workplace policies in the meantime, but this really opens up a whole new market. It's a win-win for everyone. And if we go into the age wave, we need the long-term care insurance market, the private market, to be flourishing. We need to work well. We need it to be profitable. We need it to succeed. The public sector cannot do this alone. And so that's why, Lynn and I work together. That's why a lot of people on this webinar have been working together in both spaces to try to come up with collaborative solutions.
Now, and I will just add, Ben, it's complicated. I mean, what Ben said is true, but this is complicated. And that's why it's going to require us to roll up our sleeves and get in a room, butt heads occasionally, and also just figure out what is going to be sustainable and what will work. And I will note, CareScout Insurance is a new entity. We hope to come to market in the third quarter of this year. We're not yet licensed in Washington State, but we hope to be soon. We're not yet licensed in the Commonwealth of Massachusetts, but we also hope to be licensed there very shortly, because we want to be in the business of helping you lift this program, because it is complicated and it's quite a bit of work. And I will note too that in Washington State, the benefit is $36,500, and I think that there is some provision, Ben, for that to inflate some
Automatically
good cost of living. Yes. So that is a fair amount of money, but many long-term care expenses exceed that amount. And that's why it's so important that there be a partnership with private carriers so that the coverage is more meaningful as people encounter needs.
Thanks to both of you. We've spent some time talking about the financing approach here and some of the lessons learned from Washington. I want to spend a minute to go back to some of the remarks that I think Aaron and Mark made at the outset of this webinar, really thinking about, the broad value that thinking about a sustainable solution to ensuring all people have access to equitable and affordable long-term services and supports and long-term care can have. So, I mean, at its core, right, we want to make sure that people have the ability to age with dignity, to age with the supports and the services that they need to do so, and to choose the options that are available to that they need that would be available to them. And we know that this creates, potential further opportunities for family members and for caregivers who are really stuck in this challenging place of having to choose between perhaps their own children or families and their parents, between their work and between caring for their loved ones or neighbors. And so we know that there are a variety of reasons outside of the services that are provided to the individuals who receive them, that thinking about this more broadly can have really important impacts in our community and in our society. And, there are a lot of different ways to think about that. One way I'd like to think a little bit about it for a moment, which we alluded to very briefly in the presentation from Milliman, is the impact of such a program on the existing Mass Health or Medicaid program in Massachusetts, which is, as we described currently, the payer of last resort and a predominant payer of LTSS services in Massachusetts. About a third of Mass Health expenditures are on long-term services and supports. And I think as part of the Milliman study, we identified, from June or July 2023 through June of 2024, 7 or 8 billion dollars were spent on long-term services and supports through that program. So Chris, I wonder if briefly you could just talk a little bit more about how the work considered the establishment of a program on the existing Medicaid program and what that would mean economically for that program.
Sure. Yeah, happy to touch on that a little bit. I think we all know, Medicaid program in general is a relatively hot topic in today's news, and what the future of that looks like. Is Medicaid structured in a way, to be that safety net? Are there ways you can just reform Medicaid to, repurpose it to be what it was intended for versus, we talked about some people spending down money to be on Medicaid. We also know there are instances where people who perhaps should have planned for long-term care, use Medicaid, and maybe are there other ways to think through that. Our study focused a little bit more on, if this program was in place, and it helped cover long-term care costs before Medicaid had to step in, what would be the financial implications of that. And without oversimplifying too much, I think our study generally showed that, certainly the larger the size of this new social insurance program, the more benefits you could see in terms of cost savings for Mass Health. For some of the more limited benefit programs, our analysis, and this is in the report as well, showed savings that maybe would start around in the 5 to 10% range, and then perhaps grow to 20%, perhaps a little bit further out in the projection. When you look at that catastrophic back-end program, which really covered some of those really high costs, I think Mark had talked about a small number of people, but really have a high amount of costs. That structure, perhaps would even generate some more savings for Mass Health. So I think that's part of the next phase here as you take this work forward is, what are the goals of the program? And, depending on, maybe your objectives around Medicaid savings, what you choose to design the program might look different depending on other competing perhaps objectives. So I guess the other area I would just comment on, just in terms of kind of the Medicaid funding, and Ben could probably touch on this a little bit as well. Medicaid is a jointly funded program between the states and the federal government. So any savings that will happen with this new social insurance program paying first those will kind of just naturally happen, just because all the money is staying within the state, so to speak. What you might miss out on then, though, is the federal share that was covering, half of those costs. So looking at solutions where perhaps having to file for a waiver to try and recapture some of those savings that were coming from the federal piece. Again, just another important consideration as you think about the financing. Maybe one other last clarification, I'll just turn it back over to you, Caitlin. The payroll taxes that we estimated for all of this did not use any of that savings. So all of the funding and financing for this program came solely from the payroll tax plus any investment income earned on that fund. We did not include any of the Medicaid savings to help offset any of the costs for this public program.
Thanks, Chris. Really helpful to sort of hear how you think about this program in the context of the Medicaid program, which is a huge provider of these services in Massachusetts. And I think to your point, a real focal point in the current federal political discussions and debate. Lynn, I'd love to hear if you're able to speak to, seeing the ripple effects of those families that have long-term care insurance that do have themselves structured and sort of set up in such a way that they've been able to benefit from long-term services and supports. What are the ripple effects in those situations for family members, for caregivers? How does that impact employers and employees? Can you talk a little bit about the broader impact of circumstances where people do have options in place to support them as they age?
Certainly. And thank you for the question, Caitlin. I have heard it said of caregiving that it is a great responsibility and an even greater privilege. And with that, based on my personal experience, and I'm sure many can relate, I wholeheartedly concur. However, there are significant impacts to caregivers. It takes its toll, psychologically, emotionally, physically, financially, and not to mention the strain that it can put on family relationships. So, certainly from a financial perspective, there's loss of work and loss of income. I understand that 53% of family caregivers are often late to work or they leave early. And so this starts to impact their ability to earn a living. And on top of that, they often spend their own money to help support the needs of the care recipients. As much as one survey said, $7,300 annually, or about that amount, that caregivers spend in support of the care recipient that they're supporting. So all of this means that the impact on people's financial well-being and their own retirement security is pretty significant. I understand that people turn down promotions, like 7% of the caregivers do so, and 6% even leave the workforce altogether. So we've got to enable people to be able to stay employed and get some support. So for employers out there, I wanted to note that there's so many ways that people can be supported who are in need of care, and flexible work schedules and the like really do assist. Additional paid leave helps. It's said that people are 30% more likely to stay with an employer that helps to support their caregiving needs. So that's critically important to understand, and that for every dollar that an employer spends in flexible work scheduling or telecommuting, they can receive as much as $1.70 to $4.45 in return on investment. So I would definitely encourage employers to think long and hard about how you can support people during this time. And for those people who have insurance, there's just greater optionality. It is so good to have the ability to have a say in how you're cared for and to have resources available to fund that care, to alleviate some of the pressure in the family and some of the very difficult decisions that will certainly fall on those who are responsible for care. Now, at CareScout Insurance, our parent company, Genworth Financial, has been in this business for a long time, and people with long-term care insurance still have very significant needs. Often they don't know where to go. They don't know what to do. And certainly the CareScout LLC business, our sister company, is going to help with that. I think CareScout Insurance and other carriers are looking to help people and support people and understand the need as well. So I don't want to say it's limited to us. There are other carriers in the space that I know recognize the need to do the same. Now, Caitlin, was that responsive to your question, or do you need more?
That was fantastic. And I may come back to you with some of the
Okay.
questions on outreach and education, but that was great. Before I do, Erin, I know you've done extensive research on sort of the general value of social insurance programs that help create options for people to age with dignity, to have the social supports that they need. I'd love for you to talk a little bit about your research and sort of the value of having these services available to people, particularly in a way, I think it was either you or Ben who was saying, and I've experienced this myself, when you're trying to secure these services for someone when they need them, you're always in crisis. For the vast majority of us, there isn't a plan in place. And so, there's immense value for a variety of reasons. I'd love to hear a little bit from you about some of the work you've done and what you can share with us in terms of the takeaways of the outcomes of these programs and the value of these programs.
Caitlin, thank you very much for the question. And I think it's worth elaborating a point that Ben made, namely that unlike the first national health and pension systems around the world, which arose in the late 19th century, the first public long-term care social insurance programs only appeared towards the end of the 20th century and the early 21st century. So the Netherlands in 1968, Germany in 1995, Japan in 2000, and South Korea in 2008 are leading examples of the public long-term care social insurance programs. And I make this point to say that the development of the type of systems that we're talking today is relatively recent. And so it's super innovative, the work that WACARES is doing and has done, and it's unique, is the point. So the experiences of the countries that have had these systems in place for a little bit of time can help illustrate a few reasons how long-term care finance reform can deliver significant value for Massachusetts. So first, investments in long-term care, such as the creation of a social insurance program with supplemental private coverage options, reduce the cost that families and individuals must bear. Investment in long-term care stimulates job growth in related sectors of the economy, which creates employment for a diverse workforce. Investments in long-term care also reduce this so-called implicit tax on informal caregivers by easing caregiving responsibilities, enabling workforce participation, and helping to address workforce shortages linked to population aging. And as with the Medicaid conversation, investments in long-term care can also contribute to public savings by reducing avoidable hospitalizations and lowering healthcare expenditures associated with unmet caregiver needs and caregiver burnout. I want to speak just for a minute about the example of Germany, which I've had the opportunity to study for the past year. So in 1995, actually, Germany and the United States were in similar positions in terms of, there being very limited coverage for long-term care costs. And so over about 10 years leading up to 1995, German state and local governments were regularly saying that they were unable to continue bearing the cost of a long-term care, and demographic change and the cost of care increases had made this approach to be, the local governments and state governments covering these costs to be financially unsustainable, and led to the 1995 reforms. So today, Germany has this sophisticated, bifurcated, universal, mandatory, partial cost coverage long-term care system, in which about 90% of people are covered by a public long-term care insurance program and 10% have mandatory private coverage. There is also private supplemental insurance available in Germany. About 10% of the population has these private supplemental policies. So eligible German citizens covered by the public system are able to get in-kind or cash benefits, or a combination of the two, ranging from about $1,635 per year to $26,235 per year. And this would be, as long as someone needs the care, depending on the assessed level of need. So what are the positive lessons of long-term care reform in Germany? I'll share a few. So first, long-term care costs, were publicly acknowledged as a risk to be borne collectively by German society. So it is firmly on the policy agenda starting in 1995 and remains the case. The second point is that the taxpayer contributions into the public long-term care insurance system are politically insulated. So the funds that people, the tax contributions that people make into the public long-term care insurance system cannot be diverted to other unrelated policy priorities. I think another important point is that after the 1995 reforms, provider offerings expanded significantly. The number of home and community-based service providers and residential care facilities tripled between 1995 and 2013. Another point is that, in part because long-term care is firmly on the political agenda and there is this robust financing system, there is also a fertile ground for innovation. So in Germany, particularly in Berlin, you have this ecosystem of university researchers, private firms, and nonprofits that have these incentives to innovate. And so the type of things that are happening or being thought about here range from developing artificial intelligence-driven frailty monitoring systems to help strengthen prevention, as well as building whole of society models of support for older people and people living with disabilities, which can be referred to as this caring communities idea. Now, I've talked about the positive aspects of Germany's system, and I have to say that that in the course of my research, folks also mentioned that that getting things done within this overly bureaucratic German long-term care policy landscape is a challenge. One of my German research partners put it like this: "Wir haben kein Erkenntnisproblem, sondern ein Umsetzungsproblem," which means, in other words, that people are aware of long-term care challenges in the country, but actually making change happen can be difficult, which goes to the points that colleagues on this panel have made about the challenges of working together, the challenges of collaborating, the challenges of accepting the fact that there might be differences of opinion, but if we're able to move forward on a shared basis of understanding, a consensus on some core issues, we can make a lot happen. Thanks, Caitlin.
Thanks, Aaron. There are so many additional questions I would love to ask this panel, but I am getting the sign that we need to pass the baton to our next speakers. So I'd just like to thank all of you for your contributions and just sort of acknowledge that what we sort of started with, which is this is a critical point in the process. But this is just one point in the process. And so it is really critical that we continue the energy that we have today to galvanize the messaging, the public support, the coalition of people, to ensure that we are on a journey that sets up a system in Massachusetts to make sure that all people have access to the services and supports that they need to age with dignity and to age with independence. So I want to thank all of you. And at this point in time, I would like to pass it over to Senator Jalen and Representative Stanley, the co-chairs of the Joint Committee on Aging and Independence in the Commonwealth. Thank you all.
I'm not there. I'm here. Hi. Oh, well, I just wanted to say that we started this process. We tried to start this process, and there was a long-term care financing commission that reported in 2009. And at the time, we were so hopeful because they had passed the Class Act, and we thought this is all taken care of. And so we didn't pursue it. And so I think better late now than later. This is really urgent. And I think this report really moves us far ahead. And I'll let my co-chair announce the hearing on the bill to create a commission, which is the next step.
Hi, everyone. Tom Stanley, the co-chair of the Aging and Independence Committee in the Massachusetts Legislature, along with my partner, Senator Jalen. I want to thank, on behalf of Senator Jalen and myself, Secretary Lipson, Undersecretary Mahania, everyone at AGE, HHS, Katie Walsh, the panelists, like, wow, that was tremendous. It's really exciting. Lastly, I just want to thank Alyssa Sherman from Leading Age Massachusetts and Mark Cohen, who really worked with us in getting the study funded in the last budget of the last session. So, this is very important. I'm trying not to repeat anything that's already been said, but it's critically important. The affordability is a huge issue, and we all know that it potentially could get very worse, much worse, very soon with whatever the federal government does with Medicaid funding. Senator Jalen mentioned that we have a hearing coming up, and it's critically important to hear from everyone. I know there was hundreds of people apparently on this webinar, and we have 3-minute limit of testimony, as you can see up on the screen right now. But you can also submit your testimony. It's all recorded and available on the committee website. And I think it's so what I'm talking about, excuse me, is a bill for a commission to do exactly everything we're talking about here and involve even more stakeholders, and to do so based on this actuary study, and to come up with a plan for the Commonwealth of Massachusetts. And thank you to Washington for giving us your experience and everything that we have to watch out for and so forth. So this hearing, again, we really need people. The more people that participate, the more attention it gets, and the more attention it gets with the media, and also in this building, this wonderful Massachusetts State House. And we need the attention to compete with all the other needs that are going on right now. So the bill number is 2 bill numbers that we did together: House 792 and Senate 476. And the bill specific, or we already talked about that. So just to reiterate, I think that's the most important part, and I don't need to really talk about anything else because I think it was all covered. Just thank everyone so much. This is really exciting and critically important, so we need everyone to be involved. Thank
you. Thank you to my amazing legislative colleagues. We are so fortunate to have leadership that really wants to continue to work on what we all learned this afternoon is an incredibly important, but also incredibly complex issue. So very much appreciate your leadership, and I will join the rest of you, and I will join you in encouraging the rest of the participants to participate in the hearing. I want to close us out this afternoon by sharing my deepest thanks with the Millman team for their extraordinary work and their ability to share their work in ways that we can all understand it and start to wrap our brains around it. Thanks also to Mark for setting this up so beautifully, to Undersecretary Mahania for also setting us up for a great conversation, and to Kenny Walsh for being maybe one of the best moderators east of the Mississippi, or maybe in the entire country. And to the panelists for just sharing extraordinary expertise. Thanks also to my fabulous team at Aging and Independence and at the Executive Office of Health and Human Services for being here and for designing this and for making this happen. It was really a terrific session. I believe that we have posted the link so that you can get to the study. It should be in the chat. It might show up on a slide as we close out, but again, thank you all very much. We look forward to additional conversation on this very important issue. Thanks.